Assalamu alaikum wa rahmatullahi wa barakatuhu. In the previous video, we have discussed about the basics of ECG. From today onwards, we will learn how to systematically interpret an ECG. So let's begin with the name of Almighty. So systematic ECG interpretation with the clinical 14-point approach. So whenever you see an ECG, you should see 14 points in that ECG. So step by step, we will move on to those 14 points. Okay. So a systematic 14-point approach is essential for comprehensive evaluation and preventing omissions. Okay. So first of all, whenever you see an ECG, you should have analysis of the rate and rhythm first. How will you do that? So remember, the heart rate which we calculate based upon the QRS complexes represent the ventricular rate actually. Ventricular rate. This is important because in where there are some atrial tachycardias, supraventricular tachycardias and all, or when there is AV dissociation, so you need to calculate differently the atrial rate and ventricular rate. So calculating the rate based upon QRS complexes is nothing but the ventricular rate, and calculating based upon the P waves is nothing but atrial rate. Okay, here so we will think that we are dealing with the sinus rhythm and we will calculate based upon the ventricular rate. So heart rate calculation, ventricular rate based on QRS complexes. Okay, remember when the rhythm is regular, so you will calculate as 300 divided by number of large squares between the QRS complexes. Number of large square between the QRS. Suppose if the number of large squares between the two QRS complexes is 4, then 4 divided by 75. So the rate will be 75 beats per minute, like this. Okay, this is in the regular rhythm. So in irregular rhythm, this method is not useful. What you should do is you should calculate by the ventricular rate by 6-second method. What is 6-second method? So normally in 6 seconds there are 30 large squares of ECG. So what you do is you calculate the number of QRS complexes in those 30 large squares. So that means for example, there are 6 QRS complexes in 30 large squares. That is nothing but 6 seconds. So you are having 6 QRS complexes in 30 large squares, nothing but 6 seconds. So 6 QRS complexes in 6 seconds, multiply it by 10. That will become 60 seconds. And 60 seconds is nothing but 1 minute. Okay. So 6 into 10 is equal to 60. So in the case if we take for the sake of example, 6 QRS complex in 30 large square, if it is there, to multiply it by 10, that will become 60 beats per minute. So that's how you calculate the ventricular rate in case of irregular rhythm. Okay, so that is the 6-second method. So what is the basic funda? So 30 large square represents 6 seconds. So 6 into 10 is 60 seconds. That is nothing but 1 minute. Okay. So if so you calculate the number of QRS complex, multiply by 10, that will give the ventricular rate. So normal ventricular rate is 60 to 100 beats per minute. Remember. So you have calculated the ventricular rate. Then you will assess the rhythm. How will you assess the rhythm? So whether it is regular or irregular, you will assess. Okay, so first in rhythm, when you are assessing a rhythm, first you will see the origin of the rhythm, whether it is sinus origin or it is ectopic origin, means it is from the SA node or it is other than SA node. Okay, that you will assess. How you will assess? First how you will assess is in these 3 points. So for that you will see whether the rhythm is regular or irregular. For regularity you will see the space or the distance between two QRS complexes. Two QRS complexes. If the distance between the two QRS complexes is regular, then it is regular rhythm. If it is irregular, then it is irregular rhythm. Okay. After that, you will see the P waves, whether there are P waves or not, and if they are there, what is their morphology. Okay. So you will see the P waves, and is that P wave is followed by QRS complex. Three things: if the P waves are present or not, present or not. Second thing, if present, what is the morphology? What is the morphology? Third thing, whether it is followed by a QRS complex. Followed by a QRS complex. Okay, this is important. So these three things are very important. This will determine whether the rhythm is sinus. So if it is sinus, there will be P waves, and the P waves will have a normal morphology, upward morphology. So and every P wave will be followed by QRS complex. So that is the sinus rhythm. So P waves will be positive in lead 1 and 2, and there will be one P wave per QRS complex. So just to simplify, so in sinus rhythm, the rhythm will be regular, and one P wave will be followed by QRS complex. Okay, P wave will be present, and that P wave will be followed by QRS complex, and that P wave will be positive in lead V1 and lead 1 and 2. Okay, so that's how. If it is on the other hand, it is not sinus. Okay, so the rhythm can be regular. Okay, and that P wave will not followed by a QRS complex, and P wave can be absent also. Okay, P wave can be absent also, and that P wave will not be followed by a QRS complex, not followed by minus QRS complex, and P wave will be altered morphology. So this will decide whether the P wave is sinus or non-sinus, whether the sinus rhythm is sinus or non-sinus rhythm. So you have, so what you have learned here? So number one, you have learned about the rate in both regular and irregular rhythm, how to calculate. Second, you have learned about the rhythm, whether the rhythm is regular or irregular. So this you should see. Then third, you should see whether the rhythm is sinus or non-sinus. Okay, just to summarize, in rate you will have 300 divided by the boxes number of RR, and in irregular rhythm it will by 6-second method. Regularity you will know by the distance between the two QRS complexes, and sinus rhythm whether P waves are present or absent, and what is the P wave, whether the P wave is followed by QRS complex, and what is the morphology of P wave. So these three will tell you about sinus or non-sinus rhythm. So these things you will see first of all: regularity, then rate, then sinus or non-sinus rhythm. That is the first thing you will analyze. Okay. So in rhythm there are two things: whether the rhythm is regular or irregular. Okay, and whether the rhythm is sinus or non-sinus. Okay, that is about brief about how to know the rate and rhythm. Rhythm constitutes two things: regular or irregular, and sinus and non-sinus. Now moving on towards the cardiac axis. Next you will see the cardiac axis. So the QRS axis is the mean ventricular depolarization vector in the frontal plane assessed by the hexaaxial reference system. So this I have discussed in the previous class, no, that circular diagram. Okay, here lead 1 and lead 2 ABF, here lead 2. Okay, then this is AVL, this is minus AVL, and this is AVR, and similarly here minus AVR. So all these things, this is minus AVF. So depending upon this, this is 90, this is minus 90, this is minus 180, and again this is minus 2. Okay, that is minus 150, then minus 120. So if you have this chart in your mind, from this you can derive the axis, or else we have some other methods by which we can easily find the we can evaluate the axis of the heart. So normal axis ranges between minus 90 to plus 90, and some sources says to plus 100. Okay, influencing factors, positional changes, example body morphology, may affect axis near the boundaries. So left axis deviation is axis less than minus 30 degree, right axis deviation is axis more than plus 90 degree. And one more thing is there, no, extreme axis deviation. Extreme axis deviation. What is this extreme axis deviation? So it is from minus 90 to minus 90 to minus 180. This is extreme axis deviation. Okay, so normally we will have this left and right axis deviation, so we'll discuss about that. So in normal axis, you should have in mind to know the axis, the leads which are helpful. No, 1, 2, 3 AVF leads. These 4 leads are helpful in knowing the axis of the heart. Okay, how they are helpful we will know. Okay, so now based upon this limb leads, if lead 1 is positive and lead 2 is negative, you can take this as 2 or 3. Okay, 2 or 3 we will take this as. Okay, so if it is positive and this is negative, so they are leaving, no, they are leaving, this is called as leaving. Left leaves is the mnemonic to remember this. So this is left axis deviation. So if 1 is negative and 2 or 3 is positive, so they are reaching towards each other, no, so are reaching, that means right reaches is the mnemonic to remember this. So that is right axis deviation. Okay, that's based upon 1, 2, 3. Now based upon 1 and AVF, so this is the method. So normally normal axis 1 will be positive, AVF will be positive. Now in right axis deviation 1 will be negative and AF will be positive. Same thing as 1, 2, 3, but just you are taking in place of 2 and 3 you are taking AVF. Okay, that's all. So this is right axis deviation. Here they are leaving, no, so that's why this is left axis deviation. So both are negative, this is indeterminate axis. Okay, that's how you calculate, that's how you evaluate the axis deviation, electrical cardiac axis deviation. Okay, this is the very easy method. This is important because we have in some. So after that you have seen the what you call you have seen the rate, first rate and rhythm. In rhythm you have seen whether it is irregular or whether it is regular, and sinus or non-sinus, and then axis deviation. Now you will assess the waves in the ECG, waveforms. You will assess the waveforms in the ECG, waveforms, the segments and important intervals in the ECG. Now we will see about that. Okay, so P wave represents atrial. So normally just you see this one, P wave is atrial depolarization. So normally it will be less than 3 small squares, less than or equal to 3 small squares in width and less than 2.5 small square in height. Remember this point, less than 2.5 small squares in height and less than or equal to, just remember here he has given it as 3 small squares, but you can remember it as, just remember 2.5 the unit 2.5. So it will be less than 2.5 small squares in width also and in height also, so this is easy to remember. So what is the normal metrics of the P wave? They are less than 2.5 small squares in width and less than 2.5 small squares in height also. Okay, so what are the abnormalities you see? So bifid or increased width of the P wave, increased duration of the P wave, meaning more than 2.5 small squares. Okay, or bifid meaning like this. Okay, so where you will see in left atrial abnormality, for example in left atrial hypertrophy. Okay, next, increased amplitude or peaked P wave, nothing but more than 2 or equal more than 2.5 small squares height of the P wave, so that you will see. So height is right atrium, width is left atrium. Height is right atrium, and width will give you clue to the left atrium. Remember this one. Okay, so if the height is more than 2.5 small squares, that means that has right atrial abnormality, for example right atrial hypertrophy. So remember, this is also known as P mitral, and this is also known as P pulmonale. P pulmonale. Okay. Now, decreased amplitude or absent P wave, where you will see. So in case of hyperkalemia, a moderate to severe hyperkalemia, there will be decreased amplitude of P waves, because of increased repolarization. There will be decreased amplitude of P wave in hyperkalemia and in sinoatrial block. Either there will be decreased amplitude if they are present, or they will be absent. So that is seen in, just remember, in hyperkalemia is important thing. Hyperkalemia, decreased amplitude or absent P waves. Okay. In sinoatrial block, they will be absent depending upon the degree of the block. That's all about the P waves. Okay. P pulmonale, P mitral, and absent or decreased amplitude. Next, coming to the PR interval. PR interval signifies AV nodal conduction time. So normally the PR interval is, remember, 3 to 5 small squares in width. 3 to 5 small squares in width. This is the normal width of PR interval. Okay, in width. So more than 5 small squares is prolonged PR interval, where you will see that PR interval signifies AV nodal conduction time. That's why in AV blocks the PR interval is prolonged, and also when the repolarization is prolonged, example in hyperkalemia, so the PR interval is prolonged. Okay. So in AV blocks the PR interval is prolonged, and in hyperkalemia also the PR interval is prolonged. Or in some athletes where the vagal tone is increased, there also you can physiologically see the increased PR interval also. Okay. Now, shortened PR interval, nothing but less than 3 small squares, shortened PR interval, where you will see some accessory pathway, WPW syndrome or Levin-Ganong-Lown syndrome. Okay. So accessory pathway, there you will see that is known as pre-excitation, decreased PR interval, commonly seen in accessory pathway. Remember this one, shortened PR interval you see in accessory pathway. There are two in accessory pathway, remember, WPW syndrome and LGL syndrome. You will know about this in coming slides. Okay. So that's about PR interval. Okay. Now we will know about QRS duration. Very important. Okay. QRS duration. What does QRS duration signify? It implies ventricular depolarization. Okay. And normally it is the width of the QRS complex is normally less than 3 small squares. Remember this, less than 3. Instead of telling you the 0.12 or 2.5, 0.12, so that is hard to remember. That's why I am just discussing these things in terms of small squares or large squares, which is easy to remember. Okay. So QRS width is less than 3 small squares normally. So increased width of the QRS complex, more than 3 small squares, prolonged QRS complex, where you will see commonly in bundle branch block, may it be right bundle branch block or left bundle branch block or left, and okay, in that you will see. Second is intraventricular conduction delay, when there is conduction delay, there you will see some accessory pathway. For example, in WPW syndrome, you will have an extra delta wave that will cause QRS prolongation. And in severe hyperkalemia also you will see prolonged QRS complex. Okay. So commonly just remember, in bundle branch blocks and in hyperkalemia, common things, bundle branch blocks and in hyperkalemia and in pre-excitation, meaning accessory pathway. So you will have, in these things you will have prolonged QRS complexes. So till now you have seen this hyperkalemia here also. What you have collected? So from P wave will be decreased amplitude or it will be absent in hyperkalemia. Next you will have PR interval. So PR interval will be prolonged. In case of hyperkalemia because of increased repolarization, and QRS complex will be prolonged. So decreased amplitude of P wave, prolonged PR interval, and widened QRS complex are the findings which you see in hyperkalemia. Okay. And T waves will be tented. Okay, that we will see. So moving forwards, So next, coming to ST segment. So very important. ST segment is implies early repolarization phase of the ventricles. Early repolarization phase of the ventricles. So it is isoelectric, meaning it is a straight line. It will not deviate. And if it deviates, the deviation will be less than one small square in height. One small square height deviation with that. More than one small square height deviation is considered as abnormal. Remember this point. Okay. This is given as 1 mm, just but I am talking in terms of squares. Okay, that will be EC. So less than one small square deviation is acceptable. More than one small square deviation is not acceptable. That is abnormal. So elevation is nothing but more than 1 mm in limb leads and more than 0.5 mm in, if I remember, in precordial leads. Okay, elevation or depression. But how do you determine that? By J point. We will come to that. Okay, J point, the just elevation or depression of ST segment is not required. Along with ST segment elevation or depression, the J point should also elevate or depress. Then only we will say that ST segment is elevated or depressed. This is important point to remember. Okay. Now, where it is elevated? Where it is elevated? So elevation very commonly, whenever this is elevated, this is MI. If the patient has symptoms of chest pain and ST segment is elevated, straightforward you should send troponins, and if they are regulated, it is MI. Take the patient for thrombolysis or PCI. Second common cause is pericarditis. Third common cause is early repolarization. One more thing is Brugada syndrome, which is not given here. Brugada syndrome. Brugada syndrome. Okay. So these are the four important differential diagnosis of ST elevation. What are the four important? Number one is MI. Number two is pericarditis. Okay, pericarditis. Number three is early repolarization pattern. This is also very common. Okay, in young adults. And number four is Brugada syndrome. These are the four important differential diagnosis of ST segment elevation. Just remember that thing. Then ST depression. So ST depression may signify ischemia commonly, or digitalis effect, strain pattern, or hypokalemia. ST depression you will see in hypokalemia. Remember. So number one point which should come into mind is ischemia. Okay, and commonly strain pattern also. Then you can take hypokalemia or digitalis effect. So what is the differential diagnosis of ST segment depression? Remember, ST segment depression can be in three types. Number one is downsloping ST segment depression, like this. Okay, so this is downsloping ST segment depression. This is QRS. I will just draw this one. This is downsloping ST segment depression. Number two, flat ST segment depression. Okay. Number three, upsloping ST segment depression. Then this is P wave. Okay. So this downsloping and horizontal ST segment depression is seen in ischemia. Remember this point. This is seen in ischemia. And this upsloping ST segment depression is benign, commonly seen in tachycardia. Commonly seen. Okay. That's these three types of ST segment depression you should remember. So what are the differential diagnosis? Number one is ischemia. Okay. Second is strain pattern. What is strain pattern? Strain pattern is nothing but when there is volume overload or pressure overload, the ventricles will hypertrophy. When the ventricles hypertrophy, when there is ventricular hypertrophy, there will be mismatch, demand and supply mismatch. Why? Because the heart is muscle is more, but the artery which is supplying to that heart muscle will not increase its diameter. So the diameter remains constant. So fixed supply but increased demand. That will create ischemia on exertion or at rest also in severe cases. Okay. So ischemia, ST segment depression is so in this type ST segment depression, ischemia or sometimes infarction also. So non-ST segment elevation MI, you can see depression also. Okay, so infarction also can happen in this case. So number 1 is ischemia. Number 2 is strain pattern. Strain pattern, I said strain pattern, what will happen is, so it is not ischemia. You will have like this. Okay, and then you will have depressed ST segment with inverted T waves. This is the QR, and then depressed ST segment, then inverted K wave. So this pattern is known as strain pattern, which is in case of right ventricle, this is seen in V1 and V2, and in case of left ventricle, you will see this in V5, V6, 1 and AVL, because these are left sided leads. No, just remember that, imagine that frontal plane and horizontal plane, so these are at left side. So in case of left ventricle, you will see this strain pattern in 1 AVL, V5, V6. In case of right ventricle, you will see this in V1 and V2. Okay, and in digitalis effect, you will have two types of pattern: sagging, one is sagging, and one is inverted tick. Inverted tick means normally you will tick like this. So this is something like this, inverted tick. So the ST segment will be like this. So these two types will be there in digoxin, ST segment digoxin effect. These two type of ST segment differential you will see in you will see. This is not the final thing, this is just theory. All the charts and images are there forward, we will see in detail. Okay, and in hypokalemia also we will see that. So that is about ST segment depression. Coming to the J point, important. J point is end of QRS, start of ST segment, and is also it is also isoelectric. It is in the same line. This is Q. Okay, so this line, this is straight line. Okay, this is in the same line, in line with ST segment and this PR interval line. Okay, so if from this line, if it deviates, that is ST segment elevation. If it depresses, that is ST segment depression. So this is a key landmark for elevation or depression of ST segment. By this we will say whether the ST segment is elevated or depressed by J point elevation. So J point elevation is ST segment elevation, J point depression is ST segment depression. Now coming to the T wave, this is also important. T wave is ventricular repolarization. So this is upright in 1, 2, V4, V6. Only one lead it will be inverted, that is AVR. Normally it is not inverted. Inverted is abnormal. Inverted T wave is abnormal T wave, and biphasic T wave is also there. You can see biphasic also, inverted also, tall, broad. Many kinds of T waves are there. There is a chart for that, in diagrammatic chart. We will discuss in further coming slides. This is just a table we are discussing in detail. Okay. So T wave inversion or tenting. Inversion is like this, and this inversion, in inversion you will have two things. So inversion you will have two things. Inversion you will have two things. One is like this, one is, I will say, like this. So in this you will see there is symmetrical T wave inversion, and these two limbs of the T waves are asymmetrical. So this is more problematic. This is benign actually. This is benign, and this is not benign. Remember this point. Symmetric T waves are not benign, but asymmetric T waves are benign. Remember these things. And tenting, what is that tenting? So we'll have a broad base and like this T wave, this type of T wave. This is tenting. Okay, broad base with this pointing will go off, and large T wave. Okay, you will see in hyperacute myocardial infarction. Okay, so inversion or tenting of the T wave signifies ischemia or infarction. Remember this, keep this into your mind. And second number you keep in mind is electrolyte disturbances, for example potassium and calcium disturbances, and strain pattern. This is the second number, you should keep it in mind. So ST segment, J point and T wave, these are the markers of ischemia and infarction. Markers of ischemia and infarction. Okay, remember this point: ST segment, J point and T waves. Now moving forwards, so next is the QT interval, QTC. One is QT interval, one is QTC. So QT interval is QT interval, QTC is corrected QT interval. Why we need corrected QT interval? We need corrected QT interval because QT interval is inversely proportional to the heart rate. If heart rate increases, QT interval will decrease. If heart rate decreases, QT interval will increase. That's why we need a corrected QT interval, so that that variation will not disturb us from interpreting the ECG. So we will calculate corrected QT interval from QT divided by square root of RR interval. So we will know that. Okay. So corrected QT interval represents total ventricular electrical systole. So it is less than 0.5 seconds. 0.5 seconds is nothing but less than 2.5. Remember, till now we have, I said small squares, now I am saying large square. So in QT interval it is large square. So normally it is less than 2.5 large squares. 2.5 large squares. And whenever we discuss QT interval, we discuss it in milliseconds. So 0.5 is nothing but 450 milliseconds in men, and it is 460 milliseconds in women. And it is abnormal if it is more than 480 to 500 milliseconds. More than, it is abnormal. It is considered abnormal. Corrected QT interval I am talking about. Okay. So normally how much it is? It is less than 2.5 large square. Less than 2.5 large square of the ECG. So when it is prolonged, meaning it is less than approximately 3 large squares. Okay, 0.48. So it is known as prolonged corrected QT interval. So you will see this in long QT syndrome, in hypokalemia. See again hypokalemia. So hypocalcemia. So in hypos, calcium has more to do with the QT interval. And remember, concentration of calcium is inversely proportional to the QT interval. When there is hypercalcemia, QT interval will be shortened. When there is hypocalcemia, QT interval will be prolonged. And drugs prolonging the QT interval, for example, tricyclic antidepressants, antipsychotics, macrolide antibiotics, many list of there. So QT interval prolongation is a good topic. Why this is important? When the QT interval is prolonged, the repolarization of the heart is prolonged. Repolarization is prolonged. When the repolarization is prolonged, the problem is prolonged repolarization will activate the L-type calcium channels again. These L-type calcium channels may trigger Torsades de Pointes. Okay, that is the problem. So prolonged QT interval, remember important things: drugs, hypokalemia, hypocalcemia, long QT syndrome. Shortened QT interval seen in, I said no, it is inversely proportional to calcium concentration, hypercalcemia. So increased QT interval is concerning. Okay. Then the last thing is the U wave. So that represents after depolarization or debated origin. How it originates we don't know. It has same orientation to the T wave, but it is less than or equal to 1/3 of the T wave amplitude height. Okay, remember this point. Prominent U wave, meaning more than or equal to 1/3 of T wave height, is nothing but prominent U wave. So that is seen in hypokalemia, and it is the earliest marker of, sorry, prominent U, so not earliest marker, I'm so sorry. Okay, so it is a marker of hypokalemia and long QT syndrome. You will have prominent U waves. When the repolarization, just remember this signifies again increased repolarization. So where repolarization is prolonged, you will have prominent U waves, like in hypokalemia, long QT syndrome. Inverted U waves you will see in ischemia. Okay, and left ventricular hypertrophy. Ischemia and left ventricular hypertrophy, you will have inverted T waves. So that's all about. So here we have not discussed, no, we discussed actually. T waves we have discussed, no? T waves we have discussed. So remember, in T waves, large peaked and narrow base peak T waves are the earliest marker of hyperkalemia. Symmetric, and these are symmetric, 3 points. Symmetric, narrow based, pointed T waves are the earliest marker of hyperkalemia. Okay, that's all. So we have discussed this whole table now. Okay, waveforms, segments, intervals, P wave, PR interval, everything. So chamber hypertrophy and intervals we'll discuss in the next video. Remember, this is the last thing. So normal PR interval, 3 small squares to 5 small squares. QR duration normally less than 3 small squares. Okay. So why the QRS prolongs? Remember this point. Whenever QRS prolongs only in two conditions: whenever there is an accessory pathway or when there is some bundle branch block. In these two conditions, the QRS complex will widen. Remember this point. ST segment should be isoelectric and J point should be used as a baseline reference. QT interval must be corrected due to its inverse relationship with heart rate by the Bazzett formula. So what is that? QT divided by square root of RR interval, you will give the corrected QT interval. So corrected QT more than 5 milliseconds significant increases the torsitis D point test. Remember this point. So I think this is enough for today. In the next, so first what we have learned in this video, just we will summarize. So we have learned about how to assess the rate in regular and irregular rhythm. And rhythm, we will have two things: irregular, regular rhythm, and then it is sinus or non-sinus. Then we have learned how to determine the axis. Okay. Then we have discussed about the different waveform segments and intervals. Okay, thank you for your listening. We will meet in the next video.